Greetings, I'm Zami Temesgen, Infectious Diseases, Mayo Clinic, Rochester, Minnesota, the United States. I'm very honored to be invited to share our experience with the treatment of and care of COVID-19, and I hope that our experience is of interest and useful to you. Let me share my screen. My talk today is to provide an overview of the Mayo Clinic experience with the COVID-19 pandemic. As you all realize, the events associated with the COVID-19 pandemic evolved very rapidly. It was only at the end of December 2019 that officials reported dozens of cases of pneumonia. Very, very shortly afterwards, the cause of the pneumonia was identified to be a novel coronavirus, subsequently named SARS-CoV-2. The disease was then designated as COVID-19. Within weeks, cases outside of China were reported, and essentially from multiple countries and multiple continents. The COVID-19 was declared a pandemic in March. So very quick developments, and as of last week, there have been nearly 150 million cases globally of COVID-19 and over 3 million deaths. As you know, in the Czech Republic itself, there were more than 1,500,000 cases with nearly 30,000 deaths reported. The vaccine activity has been launched, and as of last week at least, the percentage of the population that has been fully vaccinated is reported as being a little short of 9%. In the United States, unfortunately, we lead the world in the number of our confirmed cases, as well as death from COVID-19. Over 30 million, or nearly 32 million confirmed cases, and over 500,000 deaths were caused by COVID-19. Our vaccination rate is a little bit better, but still has a lot to be desired. The percentage of population fully vaccinated in the United States is about 24%. In Minnesota, where I live and work, the number of confirmed cases as of last week was a little short of 600,000 people, with over 7,000 deaths. The percentage of the population fully vaccinated against COVID-19 in Minnesota is about 26%. What I will be talking on today is, number one, how we were organized to respond to COVID-19 at Mayo Clinic, describe outcomes of Mayo Clinic COVID-19 clinical care, and then provide a description of my own involvement in a COVID-19 clinical trial. The Mayo Clinic COVID-19 response. So as everywhere, there was a lot of concern, a lot of unknown issues, and everyone was scrambling to address them to the best that they could. At Mayo Clinic, a number of teams were assembled to address different aspects of COVID-19 care and research. These include the things that are listed on the slide, including epidemiology, artificial intelligence, assay development, clinical trials, community engagement, critical care interventions, outpatient clinical trials, pediatrics, the post-COVID-19, the long haul COVID-19 syndrome, environmental risk, regulatory affairs, and so on. Most relevant to what I'll be talking today is the Mayo Clinic Enterprise Task Force, which has as its task to review all research protocols that are submitted to Mayo Clinic, review them, and approve them. The criteria for selection includes the biological plausibility. In other words, is the premise for which that intervention may work, is that reasonable, is that plausible? And that premise may be in vitro evidence for antivirals or surrogate evidence for immunomodulator therapy. The task force also made sure that there was no overlap between drugs within the same therapeutic class, and that there is no competition within Mayo Clinic for the same patients for the same class of drugs, and that there are treatment options available across the spectrum of disease, which means treatment options for people in the outpatient setting, hospitalized patients who have only moderate disease versus severe disease, or critically ill COVID-19 patients. So there are different treatment options for this, and part of the task force responsibility was to make sure that the clinical trials or the research focus should address the entire spectrum of disease. And when feasible, all efforts were made to make sure that these clinical trials or research options are available across the entire enterprise. So not only in Rochester, Minnesota, but also at the other Mayo Clinic campuses. To this end, the task force reviewed over 600 research proposals, approved 531 of those. Between March 2020 and March 2021, there have been 926 publications from the Mayo Clinic on COVID-19. These publications include articles, case reports, comments, editorials, guidelines, and so on. There have been 21 clinical trials that have been supported by the Clinical Research and Trials Unit at Mayo Clinic. Part of the COVID-19 related work is obviously the vaccine allocation and distribution. There are federal guidelines, then there are state guidelines, and the Mayo Clinic Vaccine Allocation and Distribution Work Group worked to make sure that our own work was aligned with those guidelines. Worked on staff and community education regarding vaccine hesitancy, and make sure that people understand all the aspects around vaccine, what's its efficacy, safety issues, and why it is important to be vaccinated. The approach was consistent across all of our sites, all of our campuses, and the first dose of vaccine was administered on December 21st. And I am happy to report that I was one of those first people to be vaccinated. I was also, and I am also, part of the treatment review panel, which is a group of individuals from various disciplines, including infectious diseases, critical care intensivists, and hospitalists, who met daily, twice daily on weekdays, and at least once daily over the weekends, to review all hospitalized patients with COVID-19, assess the severity and risk factors, and recommend, if indicated, COVID-19 directed therapy, as well as the best supportive care. The work of this treatment review panel was advisory and recommendations, and was done in close contact and collaboration with the actual care team, as the research team, as well as the research task force. The daily rounds of the treatment review panel provided an opportunity for us to learn from our patients, to learn from each other, to incorporate research into clinical care, and thus improve the practice. Outcomes of COVID-19 using the model of care and research that I just outlined was published recently, and I will be discussing that publication now. From March 1, 2020 through July 31st, 2020, we cared for a total of 8,512 patients with COVID-19 infection. The analysis that was published was only on 7,891 patients because 621 patients did not have research authorization in their electronic health records. The 7,891 patients were from the entire Mayo Clinic enterprise, including the Midwest at 59%, Arizona 23%, Florida 18%. There were 674 patients who were younger than 18 years, in other words, in the pediatric and adolescent population. The outcomes that I will be reporting to you now will be based on the analysis of the adult patients. There were a little over 7,200 patients who were adults. The median age for this group was 39. Women and men really made up about 50% of this group. 87.6% of the patients did not require hospitalization, so only about a little over 12% of the entire adult COVID-19 patients was hospitalized. Here is the disposition of the adult patients. On the left, you have the age distribution. As you can see, the majority of the patients, not the larger group within this age distribution is the 18 to 34 group. On the right is the ethnicity, racial and ethnicity distribution of the adult patients. Again, the large group is made by white, but other racial and ethnic groups were also represented in the patients that we saw. This is these are the baseline comorbidities of the adult patients, and as you can see on this slide, the top three comorbidities in patients with COVID-19 were obesity, chronic obstructive pulmonary disease, and diabetes. (897) patients were hospitalized, a little over 12% of the total. The hospitalized patients were somewhat older compared to the total group. If you remember, I said the median age for the entire cohort was 39. The median age for the hospitalized patients were 59. The risks for hospital admission were as follows. In a univariate analysis, age, male sex, Hispanics, and Asians were associated with a higher risk for hospital admission. In a multivariate model, increasing age, obesity, race and ethnicity, and comorbidities were significantly associated with an increased likelihood of hospitalization. ICU admission. Of the 897 patients who were hospitalized, 354 required ICU admission. The median Apache 4 score for these patients was 57. The median ICU length of stay was 6.19 days, and the mean ICU length of stay was 9.1 days. The oxygen supplementation care that the patients received while in the ICU are listed on the right aspect of the slide, with high flow nasal cannula, non-invasive ventilation, and mechanical ventilation making up the bulk of the interventions. Less than 5% of patients required, less than 5% of the ICU admitted patients required ECMO. In terms of COVID-19 specific therapeutics, 77.5% of hospitalized patients received COVID-19 directed treatment. 89.3% of ICU patients received a COVID-19 directed treatment. And more than half of the patients, 507 patients, were enrolled in a clinical trial. In terms of the type of therapeutics that patients received, 41% received antivirals, 48% received systemic steroids, 17% received monoclonal antibodies, and 21% received convalescent plasma. The complications from COVID-19 that we saw in those who were hospitalized include ARDS, acute kidney injury, thrombotic embolic complications, bacterial superinfections, bloodstream infections, and cardiovascular complications. How about mortality? The overall mortality among the 7,891 patients that we saw was 1.2. At the same period, the overall mortality reported in the United States was 3%. Among our hospitalized patients, the mortality was 7.1. The mortality rates in various cohorts reported across the United States were higher and ranged from 13.5% to 24.5%. The mortality in our patients requiring ICU care was higher, as expected, than the mortality in the overall hospitalized patients. However, it was lower than the mortality rates in various cohorts across the United States, which were reported to be in the range from 24.3 to 13.7%. The references where these numbers are derived from are available to you on that slide. So these are the outcomes, the observations that we made from the patients we saw between March 2020 and July 31st, 2020. What I would like to report on is my own involvement in specifically in a clinical trial. I was involved in a number of clinical trials, but I am reporting on a clinical trial for which I was the principal investigator. As you know, there is a very large number of clinical trials focused on COVID-19. As you can see, in mid-April of this year, there were over 2,800 clinical trials in COVID. The experimental pharmacotherapies for COVID were broadly categorized into two: antivirals and immunomodulators. Antivirals, as you know, are drugs that have a direct effect that limits viral replication, whereas immunomodulators are drugs that limit the pathological host immune response to the virus. These drugs are investigated in clinical trials and are made available through various programs, including emergency use authorization in the United States, expanded access protocols, compassionate use programs, and some drugs are approved for another indication, but have been used off-label for the treatment of COVID-19. These are just some examples of antivirals and immunomodulators that have been investigated for their efficacy and safety in the treatment of COVID-19. There is a model that has been suggested that describes the stages of disease progression with COVID-19. In the early stage, also known as the viral acute phase response, there are acute viral symptoms of fever, muscle pain, fatigue, and cough, which progress into the pulmonary phase and then culminate with ARDS and the hyperinflammatory phase. So there have been proposals suggesting that various drugs will be more effective in different phases of this model. So for example, antivirals would be active in the early infection phase, and immunomodulatory drugs may be effective in stage 2 and stage 3. This is not obviously an all or none phenomenon. There may be immunomodulatory drugs that may be effective in the early infections, such as convalescent plasma. And there are immunomodulatory drugs which are effective or presumed to be effective in the critical stage of the disease in stage 3, whereas some others would be active in the intermediate stage 2. The clinical trial that I was the principal investigator for was a clinical trial investigating the safety and efficacy of lanzilumab. Lanzilumab is a novel, high-affinity recombinant monoclonal antibody targeting the human GM-CSF. It neutralizes GM-CSF activity by blocking its binding to the cell surface receptors of GM-CSF. GM-CSF is a cytokine secreted by macrophages, T cells, mast cells, and endothelial cells, as well as fibroblasts. When I was in medical school, my understanding of GM-CSF was primarily as a hematopoietic growth factor. However, it is now understood that GM-CSF plays a key role in both innate and adaptive immunity, and that it also influences the differentiation and activation of myeloid cell subsets during the pathologic tissue inflammation. There is a phenomenon called cytokine release syndrome, which is an immune hyperresponse or hyperstimulation, manifesting itself with activation of myeloid cells and release of interleukin-6, GM-CSF, MCP1, MIP1 alpha, IP10, and interleukin-1. The cytokine release syndrome has been described in various disease conditions, including autoimmune diseases, lymphoproliferative diseases, patients receiving the chimeric antigen receptor T cell therapy, also known as CAR-T cell therapy, and now it also has been described with COVID-19. In a study from my colleagues here at Mayo Clinic, GM-CSF neutralization with lanzilumab during CAR-T therapy prevented the cytokine release syndrome and also prevented neuroinflammation. And the GM-CSF neutralization resulted also in a broad inhibition of downstream cytokines as described on the slide, or as depicted on the slide. GM-CSF has been associated with inflammatory and thrombotic consequences of the immune response. In COVID-19, GM-CSF levels were detected in the first 4 days, correlated with disease severity. GM-CSF levels were 10 times higher in patients who died from COVID-19, and elevated levels of GM-CSF were associated with risk factors for severe COVID-19. And these observations then led to investigation of lenzilumab for its potential benefit in treating COVID-19. The first investigation was a case cohort study, and this was recently published in Mayo Clinic Proceedings, and I was the principal investigator and first author for the study. We provided lenzilumab in a compassionate use protocol for 12 patients. Compassionate use is a mechanism by which drugs which have not yet been approved by the FDA, the Food and Drug Administration agency, but are required for or may be beneficial for a condition which is life-threatening, for which there are no established treatment options. To give some context to the observations that we would obtain through the compassionate use protocol, we also put together a control group of patients treated within our system during the same period in the same hospitals. And the control group was matched initially for age and gender, and then secondarily matched for disease severity. And matched for disease severity means that both the lenzilumab group and the control group were hospitalized, all had severe COVID-19, all had requirements for oxygen supplementation, but none required mechanical ventilation at the onset. These are the baseline characteristics of the patients. These are additional baseline characteristics. These are the various clinical and biomarker attributes of the lenzilumab group and the control group. What should be clear about compassionate use protocols is that it is not a typical research protocol, and we cannot mandate for certain things to be done in patients. All of those decisions, whether biomarkers are obtained, what additional medications are given, and so on, all of those are under the discretion and control of the clinical care team. So there are limitations to what we can observe through a compassionate use program. Nevertheless, the lenzilumab group and the control group were well matched. These are the results. First, the clinical outcomes. There was a faster clinical improvement that is statistically significant in the lenzilumab group compared to the control group. The improvement in oxygenations was also faster in the lenzilumab group relative to the control group. The study was not powered to give information on mortality, and therefore we do not see any differences between lenzilumab group and the control group in terms of mortality rates. However, the the incidence of requirement for invasive mechanical ventilation and/or death when combined was statistically significant, favoring the lenzilumab group. The mean oxygen saturation and fractionated oxygen, fractionated inspired oxygen ratio improvement by repeated measures from initial administration to 14 days was significantly better with lenzilumab, as was the proportion of patients who were free of ARDS over time as evaluated by repeated measures. We had one patient for whom we had pre and post lenzilumab blood available. And in that patient, we looked for various cytokines. And as you can see, there was a decrease in a large number of cytokines following lenzilumab treatment. So we concluded from this study that the pathophysiology-driven approach, the biological plausibility for why lenzilumab may work against COVID-19 is a reasonable hypothesis, and that there were encouraging observations, the ones that I just pointed out in terms of efficacy. And what I have not yet said, but what was also clear was that the safety issue was also very encouraging. There were no side effects that we could attribute to lenzilumab in the compassionate use protocol. And therefore, the observations from the small compassionate use based case cohort control study needed to be confirmed in a phase 3 randomized double-blind placebo-controlled study, which we undertook. And I was fortunate enough to be the principal investigator for that study as well. And some of the top-line results from that study are available, even though analysis is ongoing and the study has not been yet published. But I can share some preliminary results from the study. Similar to the compassionate use study, lenzilumab was given as 3 intravenous infusions 8 hours apart, and that's the entire treatment. And then there were assessments at day 28 and day 60. The primary endpoint was ventilator-free survival, evaluated through day 28. And there were a number of secondary endpoints, including ventilator-free days, duration of ICU stay, survival, and time to recovery. These are the baseline characteristics of the lenzilumab and placebo patients. As you can see, over 500. Actually, this is not over 500. These are about 236 and 243, so 250 each patients. And the baseline characteristics, while not identical, were very comparable. The preliminary analysis indicates that there was statistically significant difference in ventilator-free survival between placebo and lenzilumab, with the results favoring lenzilumab. Similar to what was observed in the compassionate use protocol, there were no additional side effects above and beyond placebo. And in fact, there were no serious adverse events that were attributable to lenzilumab itself. So this concludes my talk. To recap, I talked about how COVID-19 care was organized at Mayo Clinic and provided a brief description of the task force, the treatment review panel. Then I went on to describe outcomes of our COVID care in the period between March 2020 and July 31, 2020, referring to a publication that we just published recently. And I concluded my talk then with a description of a case cohort study and a phase 3 clinical trial for which I was the principal investigator and had to do with a GM-CSF monoclonal antibody called lenzilumab. There are a number of things unknown about the future. Will there be more surges? We are seeing some slight indications here within the United States. There are worse conditions across the world in various places, including in Europe, but also elsewhere in sub-Saharan Africa, for example, as well as in South America. Will herd immunity be achieved as a result of vaccination, as well as immunity acquired through infection? What will be the impact of SARS-CoV-2 variants on the rate of new infections, on the severity of diseases, on the efficacy of vaccines, as well as on the efficacy of COVID-19 directed treatments? There are concerns that some variants may not be well addressed by current treatments or vaccines, at least some of them. But all of this is preliminary, and the entire picture is not clear, at least not to me. How long will normality be postponed? When will we get back to the pre-COVID-19 status, whereby we can interact with each other in a normal fashion, be able to travel and interact and so on? Is there a light at the end of the tunnel, and is that light really a red herring and really not a resolution, but maybe a sign of additional complications? Or are we going to build on the advances that we had so far through vaccines and other progress that has been made across the world, and finally have this COVID-19 behind us? All of that remains to be seen, but I am optimistic, and I look forward to being able to present another talk to your Congress in person in the not too distant future. Thank you very much.